harder for people, but many thanks to those who are able to make it. This morning, we do have a special treat. We have Dr. Chris Hoffmann, Associate Professor in the Division of Infectious Disease at Johns Hopkins in the School of Medicine and School of Public Health. And he has graciously agreed to chat with us about COVID-19 and populations with HIV and TB. And I believe this is a special research interest for Dr. Hoffmann, improving outcomes of HIV and TB, especially in LMICs. Dr. Hoffmann, we often talk specifically about management of severe COVID in the ICU, but many in the group have a history of working on public health projects in infectious disease. And since the beginning of our project, there's been high demand for a chat like this. So it's a true pleasure to be able to welcome you. And I'll pass the mic over to you.
Thanks, Nico. Well, hopefully I can live up to some of the hype you've built up. Welcome everyone. Thank you so much for joining. I wear a number of hats in terms of HIV and now with the COVID pandemic. In terms of actual COVID care, I lead the guideline, Hopkins Hospital guidance for COVID care writing. I also care for patients with HIV in the outpatient setting and inpatient setting and provide inpatient COVID care. And then as Nico said, I work on HIV and TB care delivery, mostly in sub-Saharan Africa, and looking at ways to optimize and improve that. In terms of how to optimize and improve that in COVID, we'll get into that a little bit today, but I would imagine that many of the people, many of you on this call have insights to share, and hopefully we can have a little bit of a discussion around that as well. So just trying to get my, okay, so as a little outline, first, I'll cover what's known about COVID risk with people living with HIV, then COVID-19 and the role of HIV-related antiretrovirals and what's known in terms of their effect on COVID-19. Then the impact of COVID-19 on HIV and TB care, and finally, a little bit on delivering care during COVID-19. I'll note that for many of these things, there are far more questions than real solid answers, which also may be good for discussion. So starting with HIV and COVID-19 outcomes. So there have been several studies from around the world. I'll start with one from the United States with fairly early data reported to a central registry from centers all around the United States on outcomes of individuals living with HIV who were infected with COVID, either in the outpatient center setting or inpatient setting. 286 patients were included in this small study, and it only included people with HIV, so only looked at risk factors among that group in terms of worse outcomes. But as has been certainly a characteristic of this pandemic, older age was associated with greater risk of hospitalization, as was a lower CD4 count, suggesting that potentially HIV-related factors are related to worse outcomes. I will note that there's a strong association between multiple social determinants of health and hospitalization and death with COVID, and certainly also with a low CD4 count. So from this one study, I think we can say that a low CD4 count portends perhaps worse outcomes, but whether that's because the CD4 count leads to worse COVID or because of other factors compromising that individual's health also are at play. The next study to mention is from Spain. Here they collected data from 60 hospital-based HIV clinics, a total of 77,000 people with HIV receiving antiretroviral therapy were included. And within this group, 236 had a diagnosis of COVID. Compared to overall Spanish data, there was no evidence for an increased risk of COVID-19 diagnosis among these individuals on antiretroviral therapy receiving HIV care in Spain. There did appear to be a slightly higher age and sex standardized mortality among people with HIV, 3.7 per 10,000 compared to the general population of 2.1 per 10,000 from COVID-19. However, again, social determinants of health and comorbidities could have played an important role and really confounded this association, and were not able to be fully adjusted for in this analysis. Something perhaps a little more relevant to low and middle income countries. There was as far as I know, the largest study from a LMIC was from South Africa, using the public health system data in Western Cape. And there, all individuals with records, those living with HIV and those not living with HIV were included. There's over 3 million patients, 22,000 COVID diagnoses, 625 deaths, and close to 3,000 hospitalizations with COVID. And these researchers, Andrew Boole et al., performed multiple analyses in a number of ways. This here is risk for hospitalization. They also looked at risk for death, but we won't go into that given the much smaller numbers who died. First of all, if you look at the very bottom of this figure, you can see HIV. And among people who were living with HIV, you can see an increased risk. In terms of this figure, it was somewhere around 1.6 relative risk increase with people living with HIV. But I would also ask you to look higher up where it shows age and risk of hospitalization from COVID. And here you can see that age greater than 70, even greater than 40, is a far greater risk than HIV for hospitalization. Other factors, including increasing the risk for hospitalization, include diabetes, chronic kidney disease, and previous tuberculosis. Again, social determinants may be confounding the association with HIV, although it does suggest that individuals with HIV, whether it's the HIV or other background comorbidities, do appear to be at a higher risk for hospitalization, and in this study also mortality. Now I'm going to move on to the topic of antiretroviral therapy and COVID-19. So as I think everyone on this in the seminar is well aware, we have limited therapeutics for COVID-19. Currently, the ones with the best evidence, I'll mention, but won't go into any more detail, are remdesivir, dexamethasone, and dexamethasone. Early on, there was a lot of interest in antiretrovirals, and treatment protocols, especially early treatment protocols used in China, included a number of antiretrovirals, including lopinavir, ritonavir. This was actually looked at in a number of studies. One of them was a randomized trial conducted in China with 199 participants, randomized to lopinavir versus standard of care. There was no placebo, but just standard of care. The time from symptom onset to treatment was 13 days. I will note that this is sort of a long time from the time of symptom onset for an expectation of an antiviral to be effective. But the findings based on a 7-category ordinal scale were no difference between the two arms of lopinavir, ritonavir versus standard of care. Additional work on this agent, lopinavir ritonavir, has also had negative results in terms of a benefit regarding COVID-19 outcomes. Another agent that there's a lot of intriguing observational data, but no completed randomized control trials, is tenofovir, or either tenofovir disoproxil fumarate or tenofovir alafenamide combined with either emtricitabine or lamivudine. And a number of studies that have looked at overall HIV outcomes have then looked at outcomes by antiretroviral therapy. Going back to the South African Western Cape data, analysis from Andrew Bull and also Mariana Davies, suggested that there was a reduced risk of both death as well as hospitalization among those individuals with HIV who were being treated with a tenofovir-containing regimen. Now, in this area, tenofovir is the first-line regimen, part of the first-line regimen, and alternatives, including abacavir or zidovudine, are for individuals with either kidney disease in terms of zidovudine, or kidney disease and anemia in terms of abacavir, or other comorbidities for which tenofovir may be less favored. So there are certainly potential confounders again. However, it's intriguing in this study that there was a reduced hazard of hospitalization, as well as, which is shown here in this slide, but also in death among those individuals who were on a tenofovir-based regimen. Going back to the Spanish study, they also looked at the regimen that individuals living with HIV were on. And again, in this study, there was an evidence of a reduced admission to hospital as well as death among individuals on a tenofovir disoproxil fumarate, but not a tenofovir alafenamide regimen. And you can see on the first line, the tenofovir disoproxil fumarate, there, the risk per 10,000 individuals for hospital admission was 10.5 compared to 20 for all the other regimens. Again, intriguing preliminary findings regarding this agent. So there are a lot of people who are not infected with HIV who are receiving tenofovir in the form of PrEP. And another study, also from Spain, looked at individuals receiving tenofovir for PrEP compared to somewhat similar demographic who are not on PrEP. This included 500 PrEP users, either men who have sex with men or transgender men, and 250 men who have sex with men or transgender men who were not taking PrEP. And you can see first in terms of the proportion, and here they looked at SARS-CoV antibodies suggesting prior infection or recent infection. And in those who were not receiving PrEP, not on tenofovir, 9.2% of these 250 individuals had positive antibodies compared to 15% of those who are on PrEP. So far, substantially higher proportion of those who were on tenofovir actually had evidence of a prior infection with COVID. Of course, you can imagine that people on PrEP may have other behavioral differences and greater social interactions than those not on PrEP that could easily explain why they would be more likely to be exposed to SARS. In the same study, the authors tried to look at whether those individuals who had evidence of COVID had symptoms, had a longer duration of symptoms. And here are intriguing findings that potentially the use of tenofovir reduced the duration of symptoms and the severity of symptoms. Among those individuals who are not on tenofovir for PrEP, who had positive SARS-CoV-2 antibodies, you can see that 21% were asymptomatic compared to 42% who received PrEP. In addition, for those who were symptomatic, those who were not receiving tenofovir had a median of 11 days of symptoms compared to 9 days of symptoms among those who were on PrEP. I caution with any overinterpretation of this that there are considerable behavior differences between individuals on PrEP and those who are not on PrEP, as well as access to care and other considerations. So this is certainly, again, intriguing regarding the role of tenofovir, but by no means an endorsement to start using tenofovir or suggestion that it's likely to be highly beneficial. It's my understanding that there are clinical trials underway evaluating tenofovir for both the prevention of SARS-CoV-2 infection and for the management of COVID-19. Probably the area that the intersection of COVID-19 and HIV as well as TB is most notable is the potential for health system disruptions. First, it's an area that has fairly limited data, fairly limited results at this time. I'll present those that I've found, but first, the first study I wanted to discuss is one from the United States, from Boston, a system that cares for about 2,000 people with HIV. And the figure on the left, bar chart on the left, you can see the number of visits per month. Starting in 2019. In blue here are in-person visits. February 2019, still fairly high blue in-person visits. Then in March of 2019 is when COVID numbers started rapidly escalating in the Boston area. And you can see that the total number of visits actually increased slightly on this bar chart, without any decrease in the visits per month for this stable patient population. However, there was an abrupt shift from in-person to telemedicine visits. During the same time, they looked at viral load suppression. This red line shows viral load testing, and viral load testing was recommended to be delayed for patients who had been stable for a long time. So there was a large decrease in the number of viral load tests being done. But among those who were tested, the percent suppressed, which is the blue bars, remained fairly stable over time. So this shows that in a well-resourced setting where telemedicine was very feasible, the continuation of visits as well as virologic suppression was successfully managed. Now, in settings with more fragile health systems, there's certainly concern of the impact of COVID-19. Much of the information right now are guesses, models, and predictions of what may happen without a lot of current data to say exactly what is or has happened over the last 9 months. This is a modeling paper that tried to estimate the impact on both HIV care and TB care. Here I'm just showing graphs with the estimated impact on mortality, HIV-related deaths, and tuberculosis-related deaths in 2 countries, each with slightly different prevalences of HIV and TB. Based on these different scenarios regarding COVID-19, no action compared to well-managed suppression of COVID-19. And you can see here, and I would say that in terms of well-managed suppression, that's not really happening anywhere around the world. So if these modeling predictions are correct, you can see that there's a chance for a fairly substantial spike in both a high HIV prevalence country and a moderate HIV prevalence country for increasing mortality from HIV, as well as increasing mortality from TB over the coming several years. This is in years, so you would expect over the next 3 to 5 years, there would be an overall increase in mortality from these two diseases compared to what would have happened if COVID-19 were not here. Now, this model makes a tremendous number of assumptions. It assumes various levels of disruption of HIV and TB testing and care. So why do we feel like there inevitably will be disruptions? I think those on the call can probably speak to the disruptions you're seeing, but we have considerable experience from prior disruptions in fragile healthcare settings. A recent one is the Ebola crisis in West Africa, and these are graphs showing HIV testing and enrollment into HIV care during the Ebola crisis in 2014 in Guinea. And you can see in the orange line, this is 2013, prior to Ebola. The gray line prior to Ebola until about the midpoint is when the Ebola outbreak began, and there was a dramatic decrease in HIV testing to less than half of what was going on prior to the outbreak. Similarly, in terms of the number of patients enrolled in care per month, that declined sharply around the time of the Ebola outbreak. I have some more figures from the Ebola outbreak. This was fairly extensively studied. And you can see here, also in Guinea, basically showing the same thing, that as the number of Ebola cases increased in gray here, the proportion of patients who were defaulting HIV care increased greatly, and leading obviously to a direct impact from the disruption of care to disengagement in care and presumably loss of virologic suppression among these patients. Just another Ebola example, this time from Liberia, so it affected multiple health systems. And you can see here, looking over time from a greater time course from January 2012 to the point of the start of the Ebola outbreak, fairly stable HIV care visits, and then a dramatic decline. These are from, on the left-hand side, these two figures are from one hospital-based HIV clinic, and on the right-hand, a different hospital-based HIV clinic, but the impact was fairly similar in those two HIV clinics. So certainly disruption, social disruptions and disease disruptions can have a substantial impact on health delivery. There's similar findings from other settings. For example, Kenya post-election violence a few years ago also disrupted a fairly fragile health system in the western part of Kenya. What's going on with COVID-19 around the world is a little bit less clear. The WHO has some reporting. And just collecting data from countries in terms of disruption that they're reporting. And this figure just shows what the or this is actually from the Global Fund, countries reporting of those countries receiving Global Fund assistance. About a third reported low or no disruption, while 2/3 reported either from moderate to high level of disruption in their service delivery of HIV and TB care. WHO reports that 73 countries are facing risk of ARV disruption. Most of this is related to potential supply chain disruption of ARV delivery. 36 countries reported disruption of provision of ARV services. 24 countries reported critically low stocks of ARVs. And then 38 countries reported reduction in HIV testing due to COVID. The limited published and available data of what's actually happening in clinics, certainly I'm aware of anecdotal data or pre-published data on disruptions. One published piece was qualitative interviews with 100 people living with HIV enrolled in a separate clinical trial. And here there were simply questions to understand better the impact of COVID-19 on their HIV care. And 76% reported that COVID-19 negatively impacted their care. This table shows some of the more common themes. You can see that there are a large proportion of participants reported inability to continue ART visits due to a variety of potential reasons, although some reported that there was no impact on clinic attendance. One of the factors also involved, and I think many of us hear this, is that patients are concerned about exposure to COVID-19. So even if the clinics are operating and if they're able to get there, they're hesitant to travel for that reason. Among those who are actually able to get to the clinic, continue on receiving antiretroviral therapy and have that in hand, in this study, the majority stated that they had no decrease in their adherence to antiretroviral therapy. And overall, many of these participants felt because of their HIV status, they were at an increased risk for negative outcomes from COVID. So I'll finish with just some health system responses to COVID-19. So the most notable response that I've been able to identify and that has also been reported by the WHO is increasing the duration of provision of ART to multi-month dispensing in multiple countries. You can see Eswatini, 3 to 6 months for standard regimens. In some countries where traditionally the first, after initiation, a single month may be provided with expectation of return to the clinic within a month for various checks. Multi-month prescription has become more common with efforts to use cell phones for follow-up of patients. In South Africa, there's been some experimentation with home delivery of antiretroviral therapy, as well as using electronic pickup lockers to reduce interactions between health staff and patients, as well as reduce clinic crowding. So this brings me to, I think, the last point, which is that fragile health systems would benefit from strengthening in multiple ways. And a stress test like COVID-19 certainly has brought a lot of tragedy. But in terms of what we can look for as ways to learn from this, that may be how the health system is being most stressed and how we can build greater resiliency for future stresses, whether they are climatic changes, from climate change, future pandemics, post-election violence, or the many other ways that our health systems may be stressed. So just in summary, first, it's unclear whether there is an HIV effect on worse outcomes from COVID-19. Does appear that lower CD4 count may lead to worse outcomes, but there may be confounding with other social determinants of health. Tenofovir may or may not have anti-SARS-CoV-2 activity, but there are trials that are pending that may answer this question. By far, health system disruption appears to be the biggest COVID-19 related threat to people living with HIV. There are examples from well-resourced settings, like the clinic in Boston, that the use of technology can shift care to maintain excellent outcomes. However, in more fragile health systems, there are certainly questions of how we can shift to improve care delivery. And without this shift, there's certainly considerable long-term potential impact in reduced HIV testing, linkage to care, and care retention. And finally, I've spoken very little about TB, and that's because there are mostly questions and very few answers regarding TB and COVID-19. Both diseases can lead to long-term lung injury, and the combination of TB and COVID-19 certainly have the potential for additive lung injury over the long term, and potentially also worse short-term outcomes. So I'll end there and just open to questions and discussion, which hopefully we can have some. Thank you.
Thank you so much, Dr. Hoffmann, for the really excellent presentation and for taking time this morning to share your expertise with us. So we'll go ahead and open up the discussion. Feel free to raise your hand, speak up, or place comments in the chat. Bhakti, I think go ahead. We missed the first part of your question.
Sorry. I was going to say, apologies that the attendance is a bit poor. The irony is that there's a Jhpiego PEPFAR call at the same time that we hadn't anticipated. So all of our HIV focused teams are actually on a different call. So I apologize the questions are few, but it was an excellent presentation. And I think, one of the things that our Jhpiego colleagues are looking to do is, reflect on the COPs that are being settled right now, but also to understand what HIV health system strengthening activities Jhpiego should probably be supporting in view of COVID and some of the obvious barriers to service delivery. A good example of that was, we've had to halt many of our voluntary male circumcision programs. Is there any other than the allocation of multiple months of ARV doses to be given en bloc, have there been any other interventions for service delivery that have been particularly innovative or have been able to overcome some of the barriers to service delivery and in-person activities?
I think it's a great question, and I think Jhpiego has the opportunity to try to innovate in this area. I think different health systems are trying different things to survive through this crisis. Reducing clinic visits has certainly been the key thing through multi-month prescribing. As I mentioned, in South Africa, there's been some attempts for home delivery of ARVs, obviously lots of logistic challenges, and also potential for exposure of those health workers or delivery workers. I wish I had answers. I think it's a matter right now of trying different approaches. the use of cell phones has been tried, I'm aware of, in several countries. Certainly huge limitations there because it's only those individuals who one can actually reach because either they have a cell phone, the cell phone's charged, they're answering it, and those are most likely be the patients who are going to do well anyway. And it's those who have greater barriers that are more likely to be left out in a situation like this. But maybe there are others on the call who have examples of how they've been approaching this.
So I think this group is more of our vent COVID group opposed to HIV group. Does anybody have any other questions? If not, I'm going to propose that we end early since a lot of us are distracted with the activities happening in downtown DC today.
Oh, fair enough. Definitely. If there are no questions, there's no reason to stay on, but I certainly appreciate everyone's attention. Hopefully there's, oh, go ahead.
I think we have a couple. Hang on one second.
Yeah, one question. This is Adam Layton. I'm an intensivist here at Hopkins. Great presentation. I really appreciated you pulling together these studies and giving a great sense of what we know, what we don't know. Do you have any sense, I do some work in Ethiopia. I'm always very interested in technological innovations in care delivery. And I wonder, do you have a sense of some of these innovations, like the mobile follow-up and the electronic lockers? Do you think any of that's going to stick in the post-COVID era? Do you get the sense, are people actually finding that as a beneficial way of accessing patients who aren't able to make it into clinic on a regular basis? Or is your impression that when people can go back to, quote, normal, the pre-COVID normal in a post-COVID era, that we're going to go back to where we were previously?
Well, I think some changes in innovation are coming and started before COVID. So in terms of some of the attempts to use mHealth or smartphones for supporting care and even visits, especially with some populations like adolescents, they're small projects and pilots in at least South Africa looking at that. And I would imagine that as that technology improves and the penetration of smartphones increases, that will remain and be able to support people living with HIV. Similarly, with some of these smart lockers, that was in a number of countries, including South Africa, something started before COVID. And I think COVID has just highlighted the potential value for that approach. And if people, where it's working, and people are happy with not having to queue for their medications and being able to easily access medications, I think that's going to persist. Each of these approaches requires additional resources, and it's really a matter of whether those resources are able to be maintained.
Dr. Hoffmann, you presented some pretty alarming data about ARV supply chain disruptions. Do you foresee a real shortage in the future, maybe later this year? And if so, what do you think possible responses might be? Would we see rationing of ARVs or changing of clinical guidelines?
So in terms of well, first it directly impacts multi-month prescribing. So in some of the countries that have started multi-month prescribing, when there's fewer ARVs, then that has to be ended. And that's certainly happened, kind of ups and downs of how long a duration is prescribed. And I can only imagine, although there are no data that I'm aware of, that is negatively impacting HIV care when they have to shift from 3 months to 1 month or 2 weeks of ARV supply. I think in terms of, I'm sure that there's an impact in perhaps not at a national level, but in some countries at a local level, as there was during some of the other disruptions of healthcare in Western Kenya during the post-election violence. There were episodes where people were unable to access antiretroviral therapy due to supply chain disruption, as well as in West Africa during Ebola. So I think it's a risk. Right now, it appears the bigger risk is that people just are not getting to clinics to pick up medications, either because the clinics have decreased hours, or healthcare workers are focused on COVID, or are sick and not available, or patients are afraid to attend the clinics.
Thank you. If I can sneak in one more question, we shifting gears a little bit and thinking more about clinical situation and not the public health situation. We spend a significant amount of our project time supporting clinical teams who are caring for hypoxic, sick COVID-19 patients. I think we've been assuming that, in general, patients with comorbid HIV or TB, we can still kind of just proceed with the care as usual, the steroids, remdesivir if that's available. Is this assumption safe? Are there any other considerations that we should be taking into account as we support our country clinicians?
Well, I think we have very limited data. So I think right now that's sort of what you have to operate on. There are, I think, in terms of starting with HIV, two theories. One is that people with HIV and a lower CD4 count are at an increased risk for any kind of infection, including severe COVID. Not a lot of data to support that, although the Western Cape data, as well as the US registry, suggested that lower CD4 count was associated with worse outcomes. The counterpoint to that is that a lot of the worst effects of COVID for some patients appear to be from an inflammatory response, and patients with a low CD4 count may be less able to mount a robust inflammatory response and may have actually less risk of developing hypoxia. So I think we just don't know. In terms of other conditions with HIV that people with HIV are at risk for, like pneumocystis pneumonia, there we use steroids regularly, or TB use steroids regularly for an improvement of outcomes. So I would say first, the use of dexamethasone or other corticosteroids in critical illness should not be avoided in patients with HIV, but should be done just as it would be with people, with anyone else. And I think similarly with TB, use of a lot of corticosteroids could increase the risk of reactivation of TB of people with latent TB. But you have to get them through COVID and follow up what's going on with them and manage any subsequent complications. So I think that was a long answer to the question, when the answer is really, with the information we have right now, we should manage everyone with HIV or without HIV in the setting of critical illness from COVID in a similar manner.
Well, thank you. That was really wonderful. And unless I see another hand raised in the chat, I think we'll go ahead and close. I'd like to thank you again, Dr. Hoffmann, for taking some time to speak with our group. It was very much appreciated. And there may be some jealous people that missed this call who might be clamoring for you to come back. But we'll share the recording with them. And if any further questions come up later on, you